We can start the program.
Now you can start.
Yeah. Good evening, all. I welcome you all to this academic webinar on endometriosis. This is a special interest group which is on endometriosis and initiated by Indian Fertility Society. And it's a proud privilege for me to be convening this special interest group on endometriosis. It is because endometriosis is one of the enigmatic disease and a chronic inflammatory condition. Though there is a recent advances in the etopathogenesis, medical management, still it becomes unanswerable for a lot of things. So one thing to this committee, what we have planned is like, let us have a collaboration with other institutions, other chapters, and get a lot of webinars and share their knowledge or insights. So today, I think we are very proud and privileged to have the visionary leader, our national president of Indian Fertility Society, Dr. Neena Malhotra ma'am, who is a source of really inspiration, motivation for us, and really she's backing up us in whatever we are doing. Thank you so much, ma'am, and I welcome you for this webinar series on part 2. And I really like to a warm welcome to our guest of honors, the Kuldeep Jain sir, and sir is also past president of IFS. Welcome you, sir. And our mentor of SIG Endometriosis Committee, Dr. Roya ma'am. Welcome you, ma'am. And I'd like to welcome all our chairpersons, the speakers, the participants. I think we are going to have a good academic discussions with a lot of collaborations, with a lot of sharing of knowledge and having a valuable insights. With this, we'll just start with our webinar, and I like to call upon, invite our National President, Dr. Neena Malhotra ma'am, to just have the presidential address. I think everyone knows ma'am. Ma'am is a professor, head of the Department of OBJ AIMS, and now recently she has become an expert member of National ART Surrogacy Registry Board of India. And madam has chaired the sessions, and she is also a committee, clinical imaging committee of the FOXY. She has a lot of credit, like she has a lot of fellowship to her credit and awards, and have published more than 180 papers in all the peer-reviewed journals. And no other person can be chief guest to this thing other, because madam, I've seen her through the lot of, so many years, that way she's so dedicated, she motivated. Thank you, ma'am, for being a part of this webinar. I'd like her to give us few words.
Yeah. Thank you, Chitra. I respected Dr. Kuldeep, dear friend Dr. Roya, Chitra, who is the lead of this SIG. A lot of my trainees, I can see Gachdeepan, and many of my students and all the members of the Indian Fertility Society. I think it's my privilege and honor to be invited to this SIG called endometriosis. And I think if I look at my, interests clinically and in research, endometriosis is very close to my heart. Not just because it affects women with infertility, but I think as I've evolved in my career, as a postgraduate or as a senior resident or as a junior faculty, I think this disease has amazed us, appalled us. I think every day in my theater, if I do 2 theaters a day, I think the theater is full of amazing cases disguised as referred from, even patients referred from psychiatry. Thanks to the imaging, that has evolved to detect them early, or perhaps we can say we can blame it to our evolution, our way of living and eating. We are seeing many young girls come with this problem. Operating on doing an adenomectomy in a 19-year-old is what I never thought I would do when I trained in OBGYN or did gynae. But today we are doing it. Yes, if the disease is presenting early, we know we have opportunity to diagnose them, but then it is not very impressive that we have too many options to cover these young women who are distressed, are in pain, suffer with marital disharmony because of the dyspareunia, infertility. And I think it's time to say it is a division in itself. It's not a disease, it's a division. Like oncology, this needs multidisciplinary team management, where you just don't need a gynec surgeon or a laparoscopic surgeon. You need to collaborate with your colleagues in urology, in gastroenterology at times when the disease is so bad. So I think the very thought that the SIG is doing such exceptionally good work and spreading awareness, not just to our colleagues, but, in giving them insights into the newer modalities of treatment itself merits congratulation. And I think with Chitra, who's heading this SIG, she'll do wonders. She will bring laurels to the SIG, and I know her good work will keep this SIG going on to greater heights. So I wish you all a great evening, a great webinar, and a successful, and an enriching academic experience. Thank you very much. Thank you, Chitra.
Thank you so much, Ron. Thank you for the inspiring and motivation words. Really, this keeps us going and feel like doing it more. And you're really given a valuable insights to endometriosis. The importance of though we have recent advances, it's very important us to keep up to the knowledge and see that you give a better patient care. Thank you, ma'am, and thank you for taking out time and coming in the busy schedule and sharing it. Thank you once again, ma'am. Now I'd like to invite our guest of honor, Kuldeep Jain sir. Sir was a past president of IFS. He is a director of KGF and a laparoscopy center at Delhi and Faridabad. And formerly, he was a reader in UCMS and GTB Hospital, Delhi. And sir was a professor in Muzaffarnagar Medical College and is served to humanity for more than 35 years. I think sir has standardized various procedures in both obstetrics, gynecology, and has did a lot of meaningful research and publications. And also, I think sir has given a lot of training for the youngsters. I think now they become more of the specialists, IVF and laparoscopy specialists. And sir is a board of directors for Indian Fertility Society and is editor-in-chief for the Fertility Science and Research Journal, chairperson of the International Exchange Committee of IFS. He was a vice president, International Society of Reproductive Surgery. And sir is also a member of Scientific Committee for the World Congress 2025 Jaman and organizing chairperson for Fusion, which I really enjoyed at Rajasthan. Sir, we are very proud and privileged to welcome you, and please kindly share a few words.
Thank you, Dr. Chitra, for having me in this wonderful, nicely curated webinar. I'm really happy actually. Now we are having a SIG on endometriosis, and this is a really important step because we know Dr. Nina has already highlighted that this is a disease which is having a very wide spectrum of the presentation. As far as the diagnosis is concerned, we are evolving in the diagnosis as far as the imaging is concerned. But we are still looking for some clinical marker which can actually diagnose the disease very early. And that is the area where I think a lot of research is going on, and we should be able to get something as a marker for endometriosis for early diagnosis. So that is one thing which I am really interested uh, in the research area. Second thing, as far as the endometriosis and adenomyosis is concerned, we know that there might be a very complex situation in young girls. And in our country, what I feel, even the surgeons and starting uh, people who are just starting the career, they do laparoscopy. So there is a need for actually the extensive training for laparoscopy in endometriosis. When I was in Singapore, there you cannot just do laparoscopy for endometriosis until unless you are certified for the endometriosis surgery. That scenario has to evolve in India also because it is related to the fertility. And if you are doing a surgery, and we know that there is a problem of ovarian reserve in these patients, and you have to preserve the fertility by preserving the normal tissue. So I think these are the areas. One is the marker we should have. Other is the extensive training and certified training for endometriosis. So these are two areas which are in IFS. I'm hoping that all the delegates who have attended the webinar will be really benefited in their day-to-day practice. I again congratulate Dr. Chitra and her team of endometriosis for organizing such a wonderful webinar. And
Thank you, sir. Thank you so much, sir, for giving a valuable insights and telling us the awareness of the endometriosis. Now it has become a patient-centered approach, as you told, no, sir, that a person experienced in endometriosis surgery can do this. So thank you for your valuable insight, and it was a proud privilege for me that under your leadership only we have started the Indian Fertility Society Pondicherry chapter, and I'm very honored that you are being the chief guest of honor for this webinar. Thank you once again, sir. Now, I like to call upon our next guest of honor, Dr. Roya Rossetti, ma'am. Madam is the mentor of our SIG endometriosis committee, and she is at present she is a professor and HOD at the Shadan Institute of Medical Science and Research Center at Hyderabad. Madam has a lot of rollers to her credit. She was a gold medalist. She got a Best Doctor award. She won the National Academy for Medical Science award, recipient of Mridula Kamboj award, and she was the Best Chapter Secretary of IFS. She got Dira award. She got a Best Lifetime Achievement award for 2023 by Indian Fertility Society for the reproduction and fertility. She was the organizing chairperson for Fertivision 2022 and also for ISRRF. And Madam has a lot of publications, more than 100 and chapters. She has written a lot of chapters and books in the various conference proceedings. And we are privileged to have Madam as guest of honor. And she has been a guiding source for us in SIG Endometriosis Committee. Ma'am, please few words from you. Roya, ma'am. Karan, can you unmute her?
Ma'am, I request Roja ma'am to unmute herself.
Okay. I think Madam is not there. So I think when Madam joins, we'll ask Madam to share a few words and let us go without waiting for the next session. So to chair the first session, I like to call upon Dr. Shalini Chawla. She is a co-convener of SIG Endometriosis Committee. Dr. Deepa B. She is a professor and head of the Department of Ayurveda Medical College, who is having a keen interest in IVF and in preventive oncology. And Dr. Soumya, she is an IVF specialist working at Shishri Hospital. I like all the chairpersons to please kindly move forward and present the first speaker of the today. Shalini, are you there? Deepa, you can present. Deepa, you can introduce.
Yeah, to begin with the scientific session, we have Dr. Surya Prakash Murthy. She will be enlightening us on diagnosis of endometriosis biomarkers. So Dr. Surya, she has got a very great academic profile. She's a gold medalist and she has completed her MRCOG and she has she has done her ART course and she is certified in deep endometriosis laparoscopic gynecology also, and she is affiliated with many societies. Now, without further, let us move on to the session by Dr. Surya. Over to you, Dr. Surya. The screen is yours. To talk on diagnosis of endometriosis biomarkers. Because like Dr. Guldeep sir told, we all are eagerly awaiting to know further what is the updates about the endometriosis biomarkers, which is going to be the future of endometriosis diagnosis.
Ma'am, is the screen visible?
I think this thing is yeah, start. You can enlarge it, ma.
1 second. We'll do it.
Madam, I was just waiting for you. Okay. Yeah. 1 minute, Surya, before you start, our Roya madam was joined. Ma'am, Roya ma'am, please, can you share a few words for this webinar, being a mentor for this SIG endometriosis committee?
Very, very good evening to...
Yeah, we already told your achievements. I were really old and So you have
convener,
a lot
Dr.
of credit to your things. Yes, ma'am.
Chitra and Dr. Shalini. I'm very glad. But one thing I want to tell you about the biomarkers, because many times we published and basically we presented in international meet the scientists who are doing a pioneering work on endometriosis, they are not considering the biomarker anymore as a scientific evidence of endometriosis. And in fact, when we do, they are totally outright rejecting it. So I just want to tell you twice you think before you continue this research, because we were doing a lot of work. We were doing a lot of work. And we published also, even on the molecular marker also, genetic marker also, we did published, but then no, they don't even allow us to present because they don't believe. And although maybe sometimes it is useful, but the only thing which they accept as a confirmed endometriosis is basically the biopsy, the tissue biopsy, and the imaging. The next is imaging, but not biomarker anymore. That's what just wanted to tell. But anyhow, I'm glad some research she has done, but then maybe continuation of this is not worth. That's what just wanted to tell you. Because see, when we are starting some research, when we know that the end is not so optimistic and not promising, so it is like that. This is just for awareness, I mentioned. Otherwise, we did a lot of work. If you want, I can say.
Okay. Thank you. Thank you. Thank you so much, ma'am, Roya, ma'am. You being a mentor, I think you're going to guide us through a lot of things, what we went in endometriosis, and thank you for your invaluable insights into these biomarkers. And I hope you stay back with us and just give us inputs, because you have spoken so much about biomarkers. I'm surely will be privileged to share your experience. Thank you so much, ma'am. Now we'll go to our first speaker, Dr. Surya. Please, you'll be talking on your methods of diagnosis of endometriosis. Over to Surya.
Yes, ma'am. Thank you so much, and a very good evening to everyone on board. It's an immense pleasure and privilege to deliver a talk on this IFS SIG group with all the stalwarts on board. So thank you so much, ma'am, for giving me this wonderful opportunity. So talking about the diagnosis of endometriosis, that too with newer methods, which is non-invasive. As madam said, everything is under the research. So even for decades, we know that laparoscopy being the gold standard for diagnosing endometriosis, along with
Surya, unmute, no? Unmute, please. No, you've muted your speaker.
Karan, unmute Dr. Surya.
Is the screen visible now, ma'am?
No, not it. Not it.
Let me share it again.
You share it again, yes. Yeah, it's visible.
Yes. Okay. Am I audible, ma'am?
Yeah, sure.
Yes, ma'am. So we are in the era of non-invasive biomarkers. As madam discussed, it was like being laparoscopy and the histological confirmation being the gold standard in the case of endometriosis diagnosis. Then what came to the mind of researchers going into the non-invasive platform? Like there could be some diagnostic delay in getting into the hands-on with the endometriosis, being affected like 10% of the women of reproductive age group with chronic pelvic pain or infertility or unexplained infertility being affected with endometriosis. Whenever a patient walks in with infertility, we may look into all the panels on the history and what all the thing has to be investigated, but there could be some occult endometriosis which can go unnoticed unless we do a laparoscopy. So in spite of their being in the diagnosis of endometriosis in long lasting decades, that came to the development of biomarkers, which is non-invasive, easily reproducible and easily accessible, that we can repeat it whenever we want. So that lead to the platform of developing, and it is under research. It is not widely available and easily accessible. So that would be the background of getting biomarkers into the practice. So what are all the things we are going to see? Now, this is endometriosis common and underdiagnosed. We know the symptoms are non-specific. Earlier diagnosis can improve the care and the counseling as well. So when Madam informed me about the topic, I was looking into newer articles and research papers. I could see that all the articles were published on roughly around 2 to 3 years old. Like from 2022, the research came into place, and there were many newer molecules are studied in place. Even though when we do a lab for a patient with endometriosis, we see the lesion, treat it, and we can monitor. But then where comes the place of getting into biomarkers? Because I could see a lot of papers talking about diagnostic delay. But I actually wondered, because in our setup, in our Indian setup, probably we won't diagnose a delay, I think, because in NHS or US or Western countries, the NHS system even takes up to 4 to 6 weeks for patient appointment unless they come in emergency, or they may take 6 to 8 weeks for doing laparoscopy itself. Whatever it's spoken, the laparoscopy itself has its own complication. It has its own pros and cons. Anyways, that is a surgery, and that is an invasive one and expensive one. So that lead to the diagnosis of something, some panel of markers that is easily accessible. And at the same time, we can classify the patient like an early stage or occult stage or advanced stage. We can treat them and we can improve the quality of life. So with that background, we may move forward to the further studies, and the flow of talk would be what are all the markers available, and are they clinically relevant, and are they available in the market. So that's how I planned the slide. So what is the current diagnostic pathway? Whenever the patient came, like clinical history and examination, we do order for ultrasound and MRI. Obviously, lab and histological confirmation, it's the gold standard. Biomarkers can aid in support for early suspicion. Then why they are needed? Like as we discussed, it reduce the diagnostic delay and improve the patient acceptability, and we can repeat the testing over our convenience. At the same time, we can monitor her over the period of time, even after the treatment, in order to classify and look into the patient prognostic factor itself. So that has been given by a Cosgrave et al. It's a recent paper published in 2025. So, what are all the biomarkers under study? It is all the biological product like blood and serum, urine, menstrual fluid, and exosomes and multiomic signatures. These are from multiple accessible sources. It holds a promised result in getting earlier, accurate, and non-invasive diagnosis. So, these are all the biological platform from which markers are being studied. Blood-based markers. As we all know, endometriosis is something, as Madam and Sir discussed, it's a chronic pathological condition, multimodality origin affecting both inflammatory, immune response, genetic and epigenetic factors, and lot of tissue remodeling might happen. So whenever any chronic inflammatory thing happens, those markers have been released into the blood and the bodily fluids. So it's easy to collect, most practical. That includes, as we all know, the interleukins, cytokines, metalloproteinases. These are all various molecules that's been studied. For decades, the well-studied and researched molecule is CA125. We all know that's a glycoprotein that has been released from the coelomic epithelium. Whenever, like, why it's not much of in rise now? Because apart from the endometriosis, it's been raised in adenomyosis and a simple ovarian cyst, or even pregnancy and fibroids do release the CA125. That is a basic glycoprotein. But one more thing is, apart from any peritoneal chance of irritation or inflammation, that would be raised. So they looked into a marker which is more sensitive and specific and diagnostic accuracy for endometriosis in particular. And coming to the limitations, it has been studied only a small cohort of people, and also there is no proper recommendation on when to get the menstrual body fluids on any particular day. No single marker is adequate. They are looking for a panel of markers for blood, like APLA panel, attach panel. We do have multiple markers, so they are into evolving a multiple panel of markers so that the diagnostic accuracy can be improve. So what are all the candidates? Like what are all the newer markers under research purposes? So it is alpha-1 antitrypsin, vitamin D binding protein, complement related protein, like various complement involved in inflammatory pathology, and the immune mediators like interleukin 6, TNF alpha, and other matrix metalloproteinases 1, 9, and 10 have been studied, and the multiple pathways and panels are looking into forward for research purposes. And also, apart from the blood markers, they have studied also urinary markers. This paper has been released in 2015. Again, they studied in 2024, which is a urinary marker review paper, and they have included 3 to 4 markers like supraoxide dismutase, enolase, and matrix metalloproteinases. And compared to the blood marker, it is safe and non-invasive, and also outpatient friendly. We can repeat it whenever we want to repeat. We can collect it whenever needed. That reflects the systemic and local biological changes, and also that can denote the underlying disease prognosis, and also the how it affects the treatment potential as well. Coming to the menstrual fluid markers. Menstrual fluid is basically that's a shed endometrial tissue that provides a direct window to the uterine environment. What does it contain? It contains various peptides, polypeptides, and vesicles, metabolites, nucleic acid. And this is the field of research talking about the miRNA and DNA in particular. It's the biologically relevant sample type, and also it reflects what is the pathogenesis undergone. So by classifying this menstrual fluid markers, we can classify the patient of earlier diagnosis or late diagnosis, and also we can stratify the patient of simple or complex variety. So this is supposed to be a promising marker when compared to other blood and urine markers as well. And this has been discussed in a paper released in 2022, and also in proteomics paper released in 2024. So it is a promising source of biomarker and needs lot of validation studies and proper standardization, like when to collect the menstrual fluid in particular has not been clearly given in those papers. What about proteomics? Proteomics is nothing but the study of the proteins. Like genomics do tell us what gene is affected, what are all the genic variations. But proteomics in particular tells us what is actually happening inside. There are various proteins, and also they are studying thousands of proteins in this involved in the pathogenesis of endometriosis. Like collect the sample, separate the serum, do mass spectrometry, and process it. And if we want, we can combine with quantification PCR itself. So this proteomics tells us what is happening inside. Really, the patient is undergoing any chronic inflammatory pathology, and this one helps us to find out any occult endometriosis as well. But still, it's very early for the clinical application. Again, the robust validation is needed. This has been shared in the proteomics paper, which has been published in 2024. So even though it's a promising for endometriosis biomarker, again, it needs a lot of studies in future. Again, coming to this miRNA or like microRNAs, these are like regulated genetic expression, which is the underlying basic biological process. For in simple words to say, if we take DNA as a blueprint, miRNA is something, it's the controller. It takes control of everything, like when to make the gene switch on and off. So it regulates the genetic expression of profiling of endometriosis. So everything is under the control of miRNA. So whenever in the women with endometriosis, miRNA has mutated or dysregulated, everything like collapsed. There is an abnormal genetic dysregulation of miRNA. So what happens? Some coding has become overexpressed, some become underexpressed. So it is like the entire molecular mechanism which promotes inflammation, angiogenesis, tissue remodeling that become oversuppressed and undersuppressed in few areas. That leads to shedding of ectopic endometrial tissue everywhere, like all over the body. So the miRNA is an underlying etiology that dysregulates, and it's a non-coding one. Non-coding is it won't secrete the proteins, but after transcription, before converting into proteins, the entire hormonal mechanism and the gene expression has become dysregulated in endometriosis. So that ideology has been taken, and they have evolved beautifully into how to isolate the miRNAs and study. And transcriptomics is something reading of RNA. So it has been done using various techniques omics like microarray or NGS, and they sequences, and there are specific microRNA like miRNA 200 and 145 and 119. Those are all specific for endometriosis, and this one has very promising along with AI. It's involved. So whenever like a women with endometriosis walks in, collect the sample and do the MRI profiling, involve the NGS sequencing or quantify it with the PCR, and we can identify which one is earlier and which one is occult is there, or else any advanced stage. Probably we can start the treatment without even doing laparoscopy. So this has been discussed in detail about 2 papers, which is published in Frontiers in Molecular Biosciences, and also in Serum miRNA Diagnostic Model paper, which is a recent paper published in 2026. But when we look into this meta-analysis, there are various studies I can show. There are various studies looking into the forest plot. There are various studies which shows the sensitivity roughly ranges from 80 to 90%. If you look at the final study, which is published in 2023 by Zhou et al., it is 87% sensitive, and it has a very small population size, and the confidence interval is quite okay. So it is, the confidence interval varies between 0.79 to 0.93. So it clearly says it is like 87% sensitive, and also it can detect like 87% the patient with endometriosis when compared with the healthy control. And also the total studies included in this meta-analysis is 24 studies, and the total participants are 2,186. So even though it shows the miRNA as a diagnostic biomarker, but the heterogeneity and lack of standardization limited clinical implementation. At the same time, if you look into the overall combined effect, it proves to be like 82% it is sensitive. It does prove that it can detect a women with endometriosis, but it needs multiple studies for make it as a routine recommendation. But overall diagnostic accuracy of miRNA from these studies look promising. So what about exosomal miRNAs? Exosomal is nothing but when miRNA is a multiple of letters. Exosomal is something when it is everything is packed in a good envelope. Like miRNA at particular point of time, it get degraded by enzymatic degradation. So whenever it's put nicely packed in a cover, so that is exosomal miRNAs, which makes it more stable, and probably some laboratories may give in future like miRNA reporting, and exosomal is slightly advanced that, making it non-degradable by enzymatic degradation. So that's it. Again, the same technology has been used, which is mass spectrometry or NGS, and PCR can be used for quantification. So what's the difference between this? It's highly stable, and again, it's non-invasive. It can be compatible with other omics study itself. And microarray study. Coming to microarray study, this is nothing but this is a diagnostic tool, and this is a laboratory technique. So recently, just 10 to 15 minutes before 10 to 15 minutes before this study, I talked with one molecular pathologist from CMC Vellore, and I asked him whether this microarray or NGS sequencing is in practice now, because he's a geneticist working there. And he said even in Trichy, in DDC, they are doing. I think Ramani madam did a paper on biomarkers. And he also mentioned that whenever a specific consultant asks for a panel of studies, we can customize like APLA panel and TARCH panel. We can customize it, and that can be used, but it's quite expensive. And also he mentioned that microarray is not being in use now, and only for research purposes they are using all these biomarkers under NGS and quantification PCR. So we are no way farther from getting it all this into the routine use. But the thing we need to mind, it's quite expensive, because I think in US and UK they are doing it for around 500 to 600 US dollars. So transcriptomic signatures. Transcriptomic signatures is nothing but profiling, genetic profiling of endometriosis, and also studying of the miRNA, that is transcriptome. That is the commonly involved in RNA sequencing and molecular profiling of endometriosis. So multiomics integration. So this combined everything like proteomics study of proteins, transcriptomics studying of RNA and miRNA, compiling everything, coming under one roof. Like AI is included, machine learning and all AI in imaging. So everything, all biological, all markers comes into one place. So this multiomics integration, it's likely a path toward reliable and non-invasive testing. Probably in future, we may get all the biomarkers with the use of proteomics and transcriptomics. We can get a reliable and promising result in any way sooner. So that has been published in a proteomics paper and also a paper published in 2022 in Frontiers in Reproductive Health. And what about AI in diagnosis? Already AI is everywhere, like even in our fertility and embryology, in everywhere AI is there. So it has taken place. It doesn't mean that doesn't mean that AI can take place or supersede laparoscopy. It can guide people. That's what from my heart, I would say. It can guide people, or it can help. It can add on to like avoid the diagnostic delays, and also it can prevent, or it can give a proper pre-op planning. So like when to have a consultation with other surgeons, or probably when we feed everything, like when we feed the details of the patient or imaging, ultrasound and MRI, everything into an AI model, probably that would classify the patient whether the complex severity or simple type, or we need some extra planning, we need some urogynecologist or vascular surgeons nearby in place. So that can help us in a proper pre-operative planning. So it is nothing to replace the laparoscopy, that is to help us probably in coming near future. So the machine learning can combine the clinical and the biomarker data, that is planning in the complex heterogeneous disease, and also improve the prediction and risk satisfaction. So it has a strong potential to enhance the endometriosis diagnosis by integrating the multiple data available and improve the prediction of getting the patient of endometriosis or not. Probably we can plan early and improve the quality of life of the patient without wasting much time. And again, AI in imaging, probably my next speaker would talk a lot about AI in imaging. So whenever we feed so much data, it itself analyzes, and anything goes for undetectable or occult, that would help us probably for more 3D imaging or advancement, and that would plan a proper treatment potential for us to give some improved imaging performance, that will higher detection rate of endometriotic lesions, and it also characterize and stage the disease, that allows us and helps us to make a proper decision in planning a treatment. So the AI powered imaging, especially ultrasound, can enhance the detection and reduce the operator bias and improve the diagnostic confidence in treating the patient with endometriosis. There are few papers that shows a promising result of enhancing AI in imaging and involved in endometriosis. So what are all the challenges? Everything what we have talked now, all has been tested and tried in a small group of people, like 24 studies has been done, as we saw about miRNA meta-analysis, everything on small cohort, different assays, different labeling techniques, and different researchers might have done in different laboratories, and they might have used different techniques as well. So probably there's no clear-cut recommendation or when to collect the all the biological samples and menstrual cycle timing. So inconsistent timing across the studies were there. There is no consolidated recommendation to do this. So standardization protocols for sample collection processing is much needed, and the assays has to be harmonized, and reporting standard, there is some delay, and it is a diverse cohort even though they are small and heterogeneous. So it needs a lot of collaboration, like collaboration with the. Is it visible, ma'am? I think it's not visible
No,
now.
yeah, it just disappeared. Yeah.
Yeah. I don't know whether the timing has ended or not, probably.
No. We don't. We are giving such a beautiful talk. We will never stop it.
Just actually two more slides.
Yeah.
I don't
think
know what happened. Shall I reshare it again, ma'am?
Yeah, please reshare it.
Yeah, 1 second. Just 2 to 3 more slides. I don't know what happened.
Just reshare it. That will be better.
Yes, ma'am. Something interrupted. Is it visible now, ma'am?
Your screen is visible, but in front of that again you have.
Yeah.
Yeah. No, now it's fine. I disappeared again. Surya. Surya, you also disappeared. Ma'am is there. By the time Ramani ma'am, the stalwarts of endometriosis, our Ramani madam is there. By the time she can share her experience regarding MRI, and by the time she joins back, ma'am.
Yeah, just 1 second.
Ma'am, is it visible now?
No,
Yeah,
not
yeah.
yet.
No, you are visible.
Yeah. Just 2 to 3 more slides.
I will update that.
Yes. Yes. Is it visible now, ma'am?
Yes.
Yeah, conclusion.
Conclusion,
Yes.
Yeah.
right.
So again, everything future where endometriosis can be detected earlier, managed better, and lives improved. So, ma'am, when I was எனக்கே சடனா டவுட் வந்துச்சு நம்ம ஏதாச்சும் ஒன்று படிக்கும் போது தான் இதெல்லாம் நம்ம ஃபீட்ல வருமா அப்படின்னு சொல்லிட்டு. So when this suddenly appeared on my feed, so I took a screenshot of it, which is the non-surgical diagnosis of endometriosis available in USA. Then I looked into this profile of this man. He's a famous gynecologist and a fertility specialist practicing in New York. So he talked about the rapid endometriosis test to be available in NHS in England and Wales. Probably in Swiggy or Instamart, it can become soon available so that it's no near way farther getting it in hands of it. And he has also published Kate has been officially diagnosed with endometriosis done without surgery across 3 modalities like imaging, blood, and AI, all non-invasive in just 42 days. They think that in 42 days diagnosing is probably they are avoiding the delay. So anyway, sooner we can able to customize all those panels and we can get it hands on it. So, and these I took it from the net like Zivig Endo test, which is a salivary test. We can order online and get it in the delivered at doorstep itself. And also one more thing, which is Hernova Hair Resolve, is endometriosis testing that is available in NHS and also US. And I looked into the cost of it, which is around 400 to 500 US dollars. So it's quite expensive. So I think probably the future we can get a hands on all about the panel soon as like of Apple panel or touch panel we can see in near future. So it's a high time to know about it. And thank you for the wonderful opportunity, ma'am. And it was like very interesting to know about the newer things. So and update myself too. Thank you so much, ma'am, for giving me this wonderful opportunity.
Thank you, Chitra, for giving me an opportunity. Surya, I think that was an excellent presentation. So I have worked a lot in this microRNA as a non-invasive diagnosis of endometriosis. As you
Yes,
have
ma'am.
rightly said, we have done a panel of microRNAs, not a single
Yes, ma'am.
one. Okay, so
Yes, ma'am.
we did it based upon the courses study that was published in the year 2016 in Fertility Sterility Journal, where
Yes,
we
ma'am.
had taken more than 10 microRNAs. But
Yes,
then
ma'am.
doing 10 microRNAs in our setup, the cost will be very huge. So we initially tried with 6 microRNAs, which were
Yes.
very specific in our area. Like that, we came to the conclusion based upon many of the research papers we came. And then we selected this microRNA 125 and 450, 3613 and lead-7B. So in this, some of the, as you have rightly pointed out, 125, 140, 45, and these were upregulated, and lead-7B and 3613 was downregulated. But then again, what we did was we compared patients with having endometriosis proven by laparoscopy and those who are proven non-endometriotic by laparoscopy. Initially, that was our thing. And we collected the sample before posting them for laparoscopy. And from that, we did RT-PCR because NGS is quite expensive and RT-PCR is quite okay. It is reasonably to begin with, we need to spend rupees 12,000 for doing this testing. But now we are able to do it for just 4,000 rupees, 4,000 Indian money. So that means it is available in Chennai, and we tried with salivary also because it was Phillips Deschamps, past EPCOC president, who had presented that paper on that EVIC salivary test kit. Okay, that was his
Yes.
mastermind. But then in our area, this salivary thing was not unstable because probably because of the temperature. So we thought we will do it from the serum. Serum we collected in the morning and most probably in the follicular phase of the patient, and then we froze it. Okay, in deep, it was frozen, and then that is only the serum. Then we transported to the center where they are doing this mRNA testing. So we get the results within a week's time, and from 5 or 6 mRNA, now we have narrowed down to only 3. They were very specific in our population because many of the studies showed 125. If you want to have a single or a dual marker, 125 plus let7b was very significant. So again, our next thing was, this is proven versus like non-proven. Then the next study what we took was in adolescent girls. That is the age at which we need to pick up endometriosis. So adolescent girls who are complaining of severe progressive dysmenorrhea, this was one important criteria, and who are not attending the classes, school absenteeism. And in sexually active adolescent girls, dyspareunia. So these 3 symptoms we took it. Okay, then we got the testing done, and to our surprise, many of them were positive for all 3 mRNAs were dysregulated to the extent of 90%. If we had done for that, we have crossed now 300 samples, and some of the patients like clinical, now the Foxy, then Yeshre and all the societies, ACOG, everybody is for starting the treatment just with the symptoms alone. So we have one more added thing, the microRNA, plus the symptoms plus the microRNA. We started the patient on Dynages, and there was remarkable improvement of the pain. So that itself will show that the disease is responding to your treatment. And even that, some of our patients, they did not want to start the treatment without proof. So I had to do laparoscopy for those patients. To our surprise, we found that early lesions were there. One more thing is, this dysregulation was irrespective of the phenotype of the lesion as well as the staging of the disease. So even stage 1 had in fact, we had a higher dysregulation in stage 1 rather than in stage 3 and 4. So that was the conclusion of our study. And based on this, now we are planning to come out with a kit test. Soon all the basic work has been done. Probably, as you said, the next one will be NGS, microarray, and exosome study. That is also under that is also under trial. So I work with the Satyabama University, where the lab is excellent. So now they are trying to bring out with the exosomes, where you can have the signature for lifelong. And even after the hormonal treatment or any form of treatment, these mRNA dysregulation doesn't change. The signature once that is given means it remains the same. So that was the conclusion of our study, and hope I have crossed more than 700 cases, patients.
Oh, very nice, ma'am. Very nice.
So probably I want to have 1,000 cases before I could do a publication. So that will have but my preliminary publication has been already published in one of our
pilot study.
Pilot study we have published. Because as you say, even though there are many studies, cohort studies, or multicentric studies, in each center you see only they would have done 50 cases or 50 cases, 25. But ours is quite a large number. More than 700 we have now crossed. So I'm just waiting for 1,000 cases. I think it was a wonderful presentation. Non-invasive diagnosis, and added to that, AI application is very, very important. So that is why probably Chitra can take up this work. We can form a protocol where we can put in this clinical signs, symptoms, signs, imaging evidence, treatment that is given, whether it is histologically proven or mRNA.
Okay, fine.
So
then you can get an
going to feed more and more, you will be able to get from the AI, it can give you what is the phenotype, how you should go about.
Oh, that's very good, madam. Yes.
what the
We should take
treatment,
advantage of AI. It has been
yes,
taken everywhere,
yes,
at least for this.
yes.
Very nice.
So
Thank you so much, ma'am.
thank you so
Ma'am,
much.
Thank you so much for your valuable insights.
ma'am, thank you so much for your
Hey,
inputs
wait. Surya, you are
Ma'am.
not running away. Madam will ask the questions. Still, our chairpersons will ask questions.
Yeah,
Shalini, Dr. Shalini.
Yeah, thanks. That was really a wonderful talk by Dr. Surya, and the outputs that has been, and Dr. Ramani Devi ma'am has enlightened us with all the non-invasive tests. I think these are wonderful tests, and they will certainly revolutionize the treatment for the endometriosis once they come into picture. Because the early we diagnose the endometriosis, I think it is a boon that we treat these young adolescents girl early to prevent the recurrence and to maybe the early we start the treatment the better it is, and it might they stop the, I mean, not stop, but at least it will not be progressive so far if we start the treatment right at that age. And of course integrating AI will definitely help us in doing this and further analyzing, and as like Surya did mention in her presentation about the role of the AI, that we are all to involve the urologist or the surgeons so that we reach a correct diagnosis. I think it's truly wonderful to see Ramani ma'am doing so much in the field of endometriosis. We are awaiting your results, ma'am.
Thank you.
Please, you soon finish your 1,000
Yes,
cases.
1,000 cases I want to finish.
Yeah,
Surely, ma'am.
definitely,
We will
ma'am.
help you out from
Yeah.
JIPMAR. We'll do it.
Okay, sure.
Yeah,
Dr.
ma'am.
Deepa. Dr. Deepa. Deepa, unmute. Deepa is there. I think it's just. Deepa, unmute.
Sorry, ma'am, I was not able to unmute. Very nice presentation by Dr. Surya. And I have already heard once Ramani madam's talk on biomarkers. I got so much interested about that biomarker. That's why when the talk was about biomarkers in endometriosis, I told a very nice topic, ma'am. I will share the session like that. Like finally Dr. Surya was telling about it is available already in US and NHS. Probably they have already validated those things. So but in India, like madam have a very strategic thinking, like we should do a panel of test which has to be validated finally, and it will come into place, then it will be very useful. And her talk, it has started with what are the other investigations modalities which are available, and how biomarker is going to revolutionize the diagnosis of endometriosis. The talk was very nice, and you have highlighted about the proteomics and micro RNA, and how still validation is still needed, as madam was also telling. And finally she has touched about the challenges also which we'll be facing. Hope so we'll in sometime we will be starting doing this biomarkers for all the patients after it gets validated, the panel, entire panel one. Thank you, very nice presentation. Thank you, Dr. Surya.
Thank you, ma'am. Thank you so much, ma'am.
Thank you, Deepa. Yeah, Surya, I have a question. It was a wonderful, excellent presentation. I think you did not bore us with what you call sentences, and your each and every slide, no, it spoke a lot. I think that's more than a systemic representation. I just want to know, you told about the serum markers, you know, about the proteomics, everything. What now? I think all are invasive. What is the new thing, urinary biomarkers, which are coming up? Any idea that urinary biomarkers?
Ma'am,
Yes,
it's superoxide dismutase and enolase and matrix metalloproteinases are specific for urinary biomarkers. That is in study now.
Okay, so the one which I saw is like what you told is correct, Less. One I told is madam can give input like histone
Yes,
score.
histone
That is one
proteins.
is, oh yeah, and one more vascular endothelial factors. Those are the things which because for endometriosis pathogenesis, no, you need to have a angiogenesis vascular endothelial growth factor. I think I don't know how much it is true, ma'am. Can you diagnose this by urinary vascular endothelial growth factor, histones and metalloproteases?
Yeah,
Ramani, ma'am.
matrix metalloproteinases. One of my students had done a PhD there. MMP2 and MMP9, it was significantly dysregulated. So that is also, she did it from the serum. Then again with the animal model, she proved it. Okay. Then histone modification, it's like any other epigenetic change. We say that no. So histone modification in urinary thing can also be used.
So I think if this comes into know, it will be very good. Urinary biomarkers. Yeah, that's
It's easy to collect and
Collect and,
reproducible
then
also.
reproducible also.
reproducible and these things. Yeah. Thank you so much, Surya. Thank you so much, madam.
Ma'am,
Thank you, ma'am,
ma'am,
for your input. Now you
thank
tell.
you,
Now
respect.
you can tell. Yeah.
Ma'am, I want to thank Ramani ma'am for giving her wonderful inputs because she's like a pioneer in this field, giving lot of inputs about already doing it. So it's like nice feeling to listen to her and get all those inputs. Thank you so much, ma'am, for giving me this wonderful opportunity. Thank you once
Welcome,
again.
Surya and
Thank you.
Chitra, for
Thank
giving
you,
me
ma'am.
this opportunity.
Yes.
Thank you, ma'am.
Thank you, ma'am. Ma'am, you should stay back and give her more inputs. Now we are going to have for the next session too. To chair this session, I call upon my friend Dr. Gajadeepan, who is the chapter secretary of South Tamil Nadu, and he did his PG from AIMS and was senior since with us. And he's a very good academician, a great IVF specialist, laparoscopic surgeon. And one more we have Dr. Soumya. She's an IVF specialist. Again, our student. Now she's an IVF specialist as one of the private hospital in Pondicherry. I like both of you to chair this session along with me. So, Gaja, are you there? Please introduce our next speaker.
Yes, ma'am. I like to call upon the next speaker.
Yeah, Gaja, thank you for collaborating with us, and really it was very nice that we tried to make up within last 1 week and made it possible. And thank you so much for that.
Yes, ma'am. Thank you. Thank you so much, ma'am. Okay, ma'am. Let's invite the next speaker, Dr. Raja Leversi. She's a consultant in MS Hospital and Karu Fetal Therapy and Genetics and Research Institute. She has done as a MS Obstetrics and Gynecology from MS Ramia Medical College and fellowship in reproductive medicine in Dr. Nauri's Institute. She has many achievements. She was a faculty with the 26th and 2026 annual conference of ISAR, IFS, ASUOG. She's a faculty of ISUOG Maternal-Fetal Conclave 2025. She also has a faculty of 3D and 4D ultrasound training program, and she has many publications to her credit. Without wasting any further time, I like to call upon Raja Elarisi to give a talk on imaging in endometriosis.
Yes. I stopped sharing. Soumya, are you there, ma? Can you give some introductory talk? Soumya? Yeah.
So very good evening to all the respected dignitaries, esteemed faculty and colleagues joining today.
You can share joining.
So the next session, which is a very important topic in endometriosis, because this imaging is it enables early diagnosis of endometriosis, and it can provide individualized treatment protocols, and it also reduces the need for primary DHL diagnostic histolab. So it is our pleasure to have Dr. Raja Ilvarsi ma'am, who will be sharing her expertise and insights on this topic. So without further ado, Dr. Raja Ilvarsi ma'am, over to you, ma'am.
Thank you so much, ma'am, for inviting me. I would like to thank Chitra ma'am and Gajadeepan sir for introducing me. I would like to introduce myself more as a friend of Chitra ma'am and Gajadeepan sir.
Yeah, actually, I
than as
wanted
a
to tell you,
consultant.
she's always bubbly, always this thing, always ready to give an academic, and so nice to know you, Ila. Very nice.
Thank you so much, sir. So is my screen visible?
Yes, yeah, I
Yes,
think
yes,
still,
yes.
So, yes.
So put
for
in
the
a
next,
slideshow. No, slideshow, open. Yeah.
Have you got it in slideshow, ma'am?
Yeah, you got it, but go to the first slide.
No, that was only my introductory slide.
Okay, then, yes.
Yeah, so we'll, for the next 15 to 20 minutes, we'll be discussing about imaging in pelvic endometriosis. Here, I would like to stick to ultrasound because it's a quite a vast topic to discuss. And ultrasound is my field of interest. I'm not a person who does MRI. So we are going to be talking about basics of imaging in endometriosis. So when it comes to pelvic endometriosis, it can be broadly classified as imaging in ovarian endometrioma, your superficial endometriosis, and your deep endometriosis. This deep endometriosis can be further classified into your anterior, posterior compartment and your parametrium, and this is what we are going to be discussing now. So when it comes to endometriomas, it is still a lot of confusion for the general obstetricians and gynecologists to diagnose even endometriotic lesions on ultrasound. So these lesions contribute to about 10% of the general population, whereas when it comes to the infertile women, they contribute to about 25 to 40%. For women with chronic pelvic pain, endometriosis has been associated with more than 42% of population, and the incidence in India alone has been found to be 42 to 50 million, and the incidence is further rising now because of the improvement in imaging techniques and diagnostic techniques. And when it comes to the average time to diagnosis, it is somewhere between 4 to 12 years. This has been given by the WHO fact sheet just in October 25th. Still, it takes from symptom onset to diagnosis for a patient. It takes about more than 4 to 12 years, which is quite a long interval. And this can be reduced with our good imaging techniques. On moving on to ovarian endometriomas, which are commonly called as chocolate cysts, they contribute to about 4 to 5% of your general ovarian cysts. But these are the lesions where the endometrial tissue covers about 10 to almost entire surface of the cystic lesion. And why is that they have this classical appearance? We often describe, well-defined, unilocular, homogeneous, low-level internal echoes, or which is called typically as the ground glass appearance. So why is it this? Is because of the chronic collection of blood and blood products. And they are often seen in varying stages of degradation within these cysts. And these patients can classically present with probe tenderness, but long-standing cysts and chronic lesions definitely will not have probe tenderness in every imaging sitting that you're seeing these patients. And also, these patients can be broadly classified into, the lesions can be broadly classified into typical and atypical endometriomas based on your imaging findings. We just know on imaging that endometriomas can be found, but when you deep dive into these concepts, you know that they can be classified as typical endometriomas and atypical endometriomas just with your imaging techniques. So what we classically see generally, these homogeneous ground glass lesions are your typical endometriomas. That is what is commonly seen. That's why they're called typical endometriomas. And all these lesions can frequently present with this low-level echogenicities. Can you see here on this video with the addition bands? And this beautiful sign is called acoustic streaming. So what is this acoustic streaming? Because of the floating debris and products within these fluids, you can see that the particles are floating in this fluid. So you see that they're all they look like a waterfall sign. They're falling down, which is called as the acoustic streaming because of the reflection of the ultrasound waves from these products, right? So also these typical endometriomas can have something called as, can you see this flex on imaging? These hyperechoic flex on ultrasound, these hyperechoic foci are nothing but hemosiderin deposits. As and when the blood is broken down, you will have these hemosiderin deposits that are deposited on the wall of these endometriomas, which can be classically seen, which is a very typical feature of endometrioma, because endometriomas are often confused with dermoids on imaging. So when you're going to see these hyperechoic foci, which are very small linear foci, not like dermoids, you have large foci because of the hair collection and fat deposits. So these are very small linear foci and they're very classical of endometriomas. When I do Doppler for these lesions, so on a 2D image, this is how the Doppler is going to look. They are going to have a patchy vascularity. They're never having a continuous vascularity like your corpus luteum or anything. So it is often a patchy vascularity. And people who are good at 3D can get a 3D ultrasound done for these patients, and you will see the vessels are often short posed. This is because of the acute bend of these vessels on the wall of these endometriomas, giving this classical short posed appearance. This is typically described on ultrasound as bird's nest appearance. So what is this bird's nest appearance? You often see the birds making their nests, the twigs are often placed crisscross. So that is how these vessels are seen on imaging. They are often seen as crisscross images, and that's why this is called as the bird's nest appearance. This is classical of an endometrioma. This bird's nest appearance of vascularity cannot be seen on any other lesion in the ovary. What is typical endometriomas? On moving on to atypical endometriomas can present as lesions with fibrin strands, not the typical ground glass appearance. You will see hyper and hypoechoic or isoechoic areas with fine strands that are seen within these follicles and seen within these cysts, and also as irregular walls. So typical endometriomas are often seen as smooth regular walls, but atypical endometriomas can present with such irregular walls. And if you adjust the threshold a little bit and your gain settings, these lesions can even present as hypoechoic lesions. Here my gain is a little high, that's why it's looking like the reverberation artifact is looking like echoes here, but actually it was a completely hypoechoic lesion. So it can be completely even a hypo or even anechoic like an ovarian simple cyst, but you have to pick up with other lesions, probe tenderness and associated endometriomas. If you can see that hyperechoic foci flex, a small fleck here. So you have to use associated findings to rule out these hypoechoic lesions. And they can also have atypical appearance like this. You can see like solid lesions, which are homogeneous lesions, solid, thick, tenacious secretions can be there. And they can even be multiloculated. Here you see multilocate lesions. The locules are broken here and the secretions are dropping down into the adjacent locules. And they can have more of a hemorrhagic cyst appearance because of the presence of classical fibrin strands, or they can even present with complex adnexal lesions like your hematosalpinx and hydrosalpinx. This is where you have a huge endometrioma. Also with the hematosalpinx here, you can see the homogeneous blood products here filling the tube. The other atypical appearances are where you see the fluid level. Endometriomas, when you talk about endometriomas, immediately people jump to talk about fluid level. But this fluid level is actually an atypical finding, not necessarily and not often seen on your routine imaging. So this can be seen only on long-standing lesions. Why so is because, can you see there is two different surface areas within the lesion here. One is hypoechoic and one is almost isoechoic. This is because of this breakdown of the heme products and the separation of the serum from that of the fibrin products. And that's why you see the classical fluid level here. And this should be differentiated with dermoid, where you'll see a fat fluid level, and the hypoechoic area will be posterior in a dermoid. And likewise, I said they can have very thick tenacious secretions, giving an atypical appearance to the endometrioma, and they can even look solid here. If I quickly do a scan in this patient, I would have often mistaken this for a subserosal fibroid. But that's why I put the video adjacent. Can you see there is a corpus luteum there? This is a corpus luteum of the patient. And when I rotate, I can see this solid lesion and I can see the hemorrhagic area inside with the hyperechoic spots of hemorrhagic deposits there. Yeah, so you can see that. So all these are atypical presentations, and they're not going to have the typical vascular like your ovarian lesions, other ovarian lesions. When it comes to desvisualization of endometrioma, which is quite often seen in pregnant women who are long-standing women who are long-standing cases of endometrioma and then getting pregnant. Desvisualization is quite common. It can be seen in 12% of the endometrioma. So what is this desvisualization? Because of the excess hormones that are available during pregnancy, these lesions are going to be going to have increased vascular, and they're going to have different echogenicity. That's all. So they can present as thick, irregular lesions, and they have a classical papillary projection. This is because of the overproliferation of the decidual tissue. You have papillary projection inside this homogeneous ground glass appearance, which is classical of a desvisualized endometrioma. And these papillary projections often are seen late in the first trimester. And with the appearance of the papillary projection, these cysts start to increase in size. So I have had these patients typically. And when I saw her in the early second trimester, actually her size increased in size. I was quite concerned because it was increased in size and there was increased vascularity. I was worried that she should not undergo malignant transformation because she was a long-standing case of infertility with endometriosis. And then luckily, when I followed up in the third trimester, the lesion started to almost decrease in size. It reduced to a very small size. And this is the increase in vascularity you can see in such endometriotic lesions. So now we'll go to the basics. I've spoken about what is typical, atypical endometrioma and all that. So we have to know how do these endometriotic cysts actually evolve. So there is a concept where the endometriotic cysts are happening because of this metaplasia theory and all that. But there is an additional concept where you have a corpus luteum. And this corpus luteum often develops because of a break in a follicular wall. So when there is a break and there is an adjacent superficial endometriotic deposit or something, these cells enter into the wall of this corpus luteum, and which is going to be persisting as hemorrhagic cyst. And when you're going to follow up this patients after 6 to 7 weeks, they're going to be ending up with an endometriotic cyst. So even a corpus luteum that is going to be persistent can develop into an endometriotic cyst. So always be cautious in tracking your persistent corpus luteum cases. And how am I going to differentiate it? Just put your Doppler on your 2D ultrasound. The corpus luteum is going to have the classical ring of fire vascularity, just like your ectopics, where an hemorrhagic cyst will have a very minimal patch of vascularity, whereas an endometriotic cyst will have the classical short course vessels on this wall, and these vessels are going to have a higher RA when you do your Doppler for these vessels. And also know to differentiate these lesions from early endometriotic lesions from your basic corpus luteal lesion. That is also a common diagnostic confusion that many of general gynecologists have. So how do you differentiate these early endometriotic lesions is, again, do your 2D ultrasound. See, this is a very small endometriotic cyst that you can see, but look at the deposit there. Okay, that hyperechoic fleck, which are cholesterol deposits because of the breakdown of heme. So you can beautifully see it here. And again, with the help of vascularity, you can pick up these small endometriotic lesions. Here it is almost homogeneous. Only with a good resolution ultrasound, you will be able to differentiate this echogenicity, which is little hyperechoic compared to the surrounding stroma. So never get carried away by the size. Size does not correspond to the symptoms. Always remember this. There can be a small lesion which is very tender. There can be a large lesion that is almost asymptomatic. You can be incidentally finding those patients only on your routine evaluation for infertility. So never get carried away by the size and always look for pro-tenderness in these patients. When you see a small cystic lesion but is severely tender, a corpus luteum or a hemorrhagic cyst is never tender. So when you see severe tenderness in these patients, always think of endometriosis in these cases. Moving on to superficial endometriosis. So what is superficial endometriosis? These are the endometrial lesions that are happening on the peritoneal surface, less than 5 mm. Okay, that it is hardly less than 5 mm penetrating into the peritoneal surface, and they're the commonest lesions. So we always thought ovarian endometriomas are commonest, but actually the superficial endometriotic lesions are the commonest, and they contribute to about 80% of the imaging endometriotic lesions. And they can even present isolated in many cases, as common as seen in about 30% of the patients, the isolated lesions. Just superficial endometriosis alone without a coexisting deep endometriosis or an ovarian endometrioma. And mostly these patients are asymptomatic. This is what is quite alarming in these patients, because even the images that I'm going to be showing you subsequently, majority of these patients came just for infertility ultrasound. I picked them to have superficial endometriosis on a routine infertility imaging, and they never came with any symptom. Or if in case they're going to come with symptoms, they may present with the pelvic pain or dyspareunia or infertility, as we all know. And there are multiple papers saying the lower BMI patients, the thin patients, are said to have more severe form of superficial endometriosis than the obese population. This is probably the metaplastic theory. We don't know, but there are a lot of papers that have come up regarding this. And how do you see these lesions? They can be having multiple appearances on your ultrasound. They can present as hypoechogenic lesions or as clustered vesicles or hyperechoic foci, which will be seen subsequently. And people who are interested in superficial endometriosis and imaging in superficial endometriosis can go through this IDEA group's addendum, which has been published in SIG 2025. IDEA group is a subgroup of people who have been doing a lot of work on imaging in deep endometriosis, and they have come up with the fact that a transvaginal scan is more than enough to see to superficial endometriotic lesions, and you need not jump in for an MRI to get your superficial endometriotic lesions. In fact, ultrasound can pick them up more easily. So that is more than enough. So this is the final conclusion of that particular group that has studied superficial lesions. And when we'll be seeing every subtype of that lesion one by one. The first subtype is where you're going to have hypoechogenic tissue and vesicles. So what are these hypoechogenic tissues? Can you see this? This is the normal peritoneal surface of that particular patient, and this tissue is relatively hypoechoic compared to the surrounding peritoneal tissue. And can you see the small vesicles there? So all these are the endometriotic lesions that you are seeing in these patients, and this is what you see in laparoscopic as a typical clear vesicles on your laparoscopic imaging in these patients. And the next subset of population is where they're going to have an hyperechoic convex lesions. Can you see this? This is a patient where the uterosacral ligament is attached to the uterus. This is called the point called torus utrinus. So at the end where the uterosacral ligament is attached, you're able to see a huge hyperechoic foci here. And you can see multiple foci. This is a bowel of that patient where there was an hyperechoic foci. And here you can see on the bowel there are hyperechoic foci. And look at this small hyperechoic foci and ovaries. So much vascularity when I put the Doppler on that. And for this bowel lesion, you can see that vascularity. I'm talking about superficial lesions, not the deep lesion of bowel. Okay. And here you have again a superficial lesion on the ovary here. So all these lesions are very classical of superficial endometriosis, and they're quite clearly seen when you're going to have fluid around, because the fluid is anechoic and is going to enhance these superficial lesions, and we are going to be able to see it more clearly than when there is no fluid around. And I was lucky for all these patients, I had some amount of fluid, and for some patients I had instilled fluid to do it, which we'll be discussing in subsequent slides. So this is what appears as laparoscopy as your clear red lesions, which are thick hyperechoic red lesions. And moving on to the next level of imaging is where you're going to have hyperechoic spots. They can just present as hyperechoic spots on the surface of your peritoneal lesions or on your ovary or on the peritoneum. Here, even on the bowel, you can see here. Can you see that spots on the bowel wall here? These are all superficial endometriotic lesions. And in this case, you can see the superficial endometriotic deposits that are going along the peritoneal surface, and which is close to the ovary here. So they are very clearly seen. These are your classic black or the dark red spots that you see on your laparoscopy. So these are those hyperechoic spots that are seen on ultrasound. And you can have something called peritoneal pockets. So what are these peritoneal pockets? You have these lesions, endometriotic lesions, which are going to have a lot of fibrosis around them. So what does this fibrosis do? It's going to keep pulling the peritoneal surfaces, creating deep pockets within the peritoneum. And that is what is imaged on ultrasound as these peritoneal pockets. You can see these endometriotic lesions causing surrounding fibrosis. You can see how thick the serosal surface is here. So causing so much of fibrosis and pulling the peritoneal surfaces, causing a formation of such deep pockets. So even here you can see, and when you put the Doppler, you'll see the vascularity of these lesions. And look at the peritoneal thickening and inflammation here. So much of thickening. In all these pockets, you can see the regular walls of peritoneal pockets here. So all these are peritoneal pockets. That is what is seen in laparoscopy as these deep pockets of peritoneum. I'm showing you the corresponding ultrasound images with the laparoscopic images so that you can understand these lesions better when it comes to imaging. So they can also thin flimsy adhesions that we know very well. Okay, so these are adhesions between the peritoneal surface, and here there are adhesion and here you can see the adhesion bands extending, and here you see the acoustic stream. So they are the classical adhesions that you see in laparoscope. So to visualize these lesions is quite easy if you're going to have fluid. I already mentioned this. So that is when you can do something called a sonopodography. So sonopodography, the name speaks for it. Just we have to put 20 ml of saline into the POD through the uterus, just like you do your HSG. You put 20 ml of saline into the POD and you will be able to very clearly visualize these adhesion lesions. And not only these adhesions, even the superficial deposit. Can you see the superficial deposit, which would have otherwise not be seen? When I put fluid into the POD, you can classically see the superficial deposit here, and you can even see the vascularity for that lesion. So this doesn't mean you can do sonopodography for all the patients just because you want to see a superficial endometriotic lesion. No. So you can use in these patients who are symptomatic, but there is no evidence of any deep endometriosis or endometrioma because this is quite time consuming and you cannot randomly post all patients. And there is also going to be a slight risk of infection if they're going to have an PID. So always be cautious when you use such invasive techniques. So not for all patients. Now we move on to deep endometriosis. So what we have seen is ovarian endometrioma and superficial. Now what we are seeing is deep endometriosis. Deep endometriotic lesions are the one which are going 5 mm below the peritoneal surface, and these contribute to about 15 to 30% of your endometriotic patients. So DIE can be anterior and posterior, as I already said. Also the radial compartment, which contributes the parametrium. We'll discuss the posterior first because the posterior is quite more common, as we all know, because the uterosacral is the most commonly involved side next to your bowel endometriosis. So the most common is your uterosacral. Next comes your anterior muscularis of the rectum and sigmoid. Next comes your vaginal wall, cervical lesions, and all that. So they can either be asymptomatic, or these patients can present with deep dyspareunia because of the lesions being deep-seated. So they can come with painful intercourse or a chronic pelvic pain, or they can come with bowel symptoms like dyschezia and all that, especially when they're menstruating, when they're prior to menstruation, they'll say sometimes they even pass blood in motion. So these are the symptoms they're going to be presenting with all your DIE lesions. So how do I measure these lesions and how do I see these lesions? So all these lesions most of the times are hypoechoic and they're heterogeneous. So they can either be hypoechoic as the first image, or they can be heterogeneous as the second image, having both hyperechoic shadows within an hypoechoic lesion. So they can present both the ways. They can present as fusiform irregular lesions with diffuse borders. The borders are not very clearly defined all the time. Or they can even present as firm lesions, often casting a shadow because of the firm fibrosis within the lesions. Or they can present as hyperechoic foci that we saw earlier. Okay, a majority of my cases are hyperechoic here. And they can even present as hyperechoic foci, okay? And always look for tenderness, okay? And these lesions, be particular about seeing the vascularity of these lesions. I will tell you why in the subsequent slide. And remember that all endometriotic lesions, especially the deep endometriotic lesions, have to be measured in 3 orthogonal planes. The longest plane, longest diameter, always trace the lesion. Do not use the direct arrow. I have showed both the things here because the entire length will be missed if you're going to just put your straight arrow and measure these cases. So you have to take a proper length, trace and take the length of the lesion and rotate the probe 90-degree anti-clockwise and take the transverse width of these lesions. That is how we measure all your endometriotic lesions. And why vascularity? See, often I'm going to have patients who are going to have a lot of deep endometriosis involving the bowel. So for all these patients, I cannot be saying, see, so much of bowel is involved and see only this much of bowel lumen is left behind. So you have bowel symptoms because of the lesion compressing on the bowel. Come on, undergo a resection and anastomosis. It's not quite easy for the patient to undergo. So for all these patients, what I can do is I can put the Doppler. And 2D Doppler might not give me much of information because for the same lesion, I've done 3D Doppler here. You can see the difference in vascularity. 2D is vascularity in a single plane. So I have to swipe through the lesion to get the entire vascularity of the entire lesion. So rather, if I'm going to do a 3D power Doppler for these lesions, for the same lesion, look at the vascularity. It is so vascular. And this is one of my patients who is currently on treatment. She is only on medical management. She's not undergone any surgical treatment because she's already undergone 4 surgery for endometriosis from 3 different consultants. She was not ready for another surgery and definitely not ready for a bowel resection. So she's almost more than 3 years on follow-up with me, and she's only on oral Dynogest now. Initially, she was on leuprolide. Now she's on Dynogest, and she's doing quite well without a need for another surgery, just because the vascularity was assessed better and she was guided better, and she did not need another surgery. So how to locate these bowel endometriotic lesions? So how am I going to do it? So I get the uterus in plane and I try to get the bowel in plane along with the uterus. And when I'm going to see the correlation of the bowel with the uterus, I'm going to get to know where this lesion exactly lies. Okay. So the lower cervical and the lower uterine area, if the bowel is going to be lying near these areas, they are the lower rectal lesions. And if the bowel lesion is going to be somewhere close to the upper uterine segment, that is going to be upper rectal lesions. Close to the fundus is your ectosigmoid, and above your fundus is your sigmoid lesions. So that is how I classify my bowel endometriotic lesions based on the location when I track them on ultrasound. And the second important thing I have to see in bowel endometriosis is for something called sliding sign. I can see anterior and posterior sliding sign and upper and lower sliding sign. So what is this? On all directions, if you can see, I'm rotating the probe in all directions and seeing whether the bowel is moving freely. So anterior, posterior, upper and lower. So all areas the bowel should move freely, and then I'm quite sure that there is no bowel adhesion or endometriosis in these lesions, in these patients. And otherwise, there is going to be an adhesion. You can see in this image, you can see the ovary moving along with the uterus when I put pressure, but it's not moving away from the uterus. It's not sliding away from the uterus. So and that is the point that you just saw, is where the ovary is actually adherent to the uterus. That's why it's not sliding separately. So this is sliding sign negative and this is sliding sign positive. Okay. So the next thing is how to suspect these lesions. Okay, once I have seen my sliding sign, how am I going to suspect these lesions on my ultrasound? So I do my routine 2D ultrasound, and when I see these, there is some problem here. That is what I'm able to pick up. So what am I able to see here is there's an ovary here, there's an uterus here. I'm sorry, I clicked on this slide. So there's an ovary and a uterus here, and you can see this plane of serosal integrity is lost, classically lost here. I can see this endometriotic lesion entering onto the uterus, creating a foam. Now, there is a lot of discussion about posterior adenomyosis. So this is this classical foam in this patient because of the loss of serosal integrity. So this is one clue for us to diagnose, yes, there is a problem here and this patient can have endometriosis. So always look for serosal integrity in all your deep endometriotic lesions. Even if there is going to be a bowel here, again, I'm going to see if there is going to be loss of serosal integrity. And you can see the patchy serosal continuity here. And here is actually a bowel. Can you see this is short axis of the bowel, and there is a patchy loss of integrity here. Okay, and the second thing that you have to look is presence of echogenic irregularities on the serosal surface. In the last image, you can see on the cervix, there are a lot of echogenic irregularities, and you can see the cervical surface is very irregular in these patients. And the presence of turbid fluid and adhesions along with this is going to help my diagnosis quite easier when I'm going to look for deep and superficial endometriotic lesions. Now I move on to bowel lesions first. I'm not talking uterosacral first because there is a lot to discuss about bowel lesions and imaging in bowel. So let's cover bowel first and then moving to uterosacral, because though uterosacral is commonest, let's discuss bowel. So these bowel lesions can be appearing as hypoechoic lesions or as solid lesions. One thing that you should always remember is when it comes to bowel, always look for this triple line in the bowel wall. It's very important. So this is when your longitudinal and the circular muscle fibers are divided. So always this triple line should be maintained along the bowel wall. When there is a loss of this triple line, that is when you're going to have an endometriotic lesion. So, and you can see how much this is an mushroom-shaped lesion, and you can see it is compressed bowel so much, only so much of lumen is left behind, and she will present with severe constipation. Okay. And what is this mushroom sign? Because of the fibrosis that is happening in these endometriotic lesions, the muscularis is pulled, both the ends of the muscularis is pulled together like this. So that's why giving a mushroom-shaped appearance here. The next sign that you have to look in your bowel endometriotic lesions is your comet sign or the tail sign. You know the comet or the shooting star, no? It leaves behind a long tail. So likewise, you look at these bowel lesions, they're leaving behind a long tail because the endometriosis is spreading along the muscularis in these patients. So that's why it's called as the comet sign. So next sign will be your signet ring sign. So what is the signet ring sign? So in all these patients, when I'm going to take a short axis image of the bowel, it's quite difficult to see on long axis. So I rotate the probe 90 degree anti-clockwise and I will get the short axis of the bowel. So when I see the short axis of the bowel, I can see the endometriotic lesion standing out separately, widening the muscularis there. So that's looks classically like your signet ring wound during those olden days. So which has a broader front face of it. So similarly, you have a broader lesion anteriorly, and then you have the short axis of the bowel. So that's why it's called the signet ring sign. And red Indian headdress signs. So lots of signs, quite interesting in ultrasound imaging. So what is this red dress sign? So in red dress sign, I'm able to see, this is a video that I put here, I put it on loop mode. So you can look at this mucosal surface is pulled towards the endometriotic lesion because of the fibrosis that's happening, giving the classical appearance of the feather placed on the red Indian head cap. Okay, so that's why you call this as the red Indian head sign. And then you have the pulling sleeve sign. So what is this pulling sleeve sign? When the shirt is pulled up, you can see multiple folds here. Likewise, because of the chronic fibrosis and the pulling of the mucosa towards the endometriotic lesion by the fibrotic strands, you can see this pulling sleeve sign that you're seeing here. Okay, so that is what is called pulling sleeve sign because of the pulling of the mucosa towards the fibrotic endometriotic lesions. So when it comes to deep endometriosis, in imaging, always get the short axis of the bowel. Also, not only look in the long axis that I have shown previously, always look for short axis because you will get the correlation of the image very clearly. Here you see the ovary, here you see the uterus. Here is the short axis of the bowel with the endometriotic lesion, which is adherent between the uterus and the ovary here, and was negative for sliding sign. And here you can see there are superficial endometriotic deposits. Also here there is an hyperechoic deposit and a deep endometriotic lesion on the bowel here. Again, I'm showing it on short axis. And here I have a bowel on short axis and a DI lesion going from the ovary towards the bowel here. So I can see the endometriotic lesion here. And sometimes what happens is these bowel lesions can also have or even not only bowel lesions, any deep endometriotic lesion can have omental patch being stuck on these lesions. So giving an irregularity for the irregular or heterogeneous appearance to these deep endometriotic lesions. So may not get confused. This is because of the omental patch sticking on these lesions. And they can be even having increased vascularity, all these lesions. So now we move on to the uterosacral D. So uterosacral disease, as I already said, it contributes to about 60 to 70% of the women with deep endometriosis. So coming to, let's talk quickly on the basics. So you have the uterosacral attaching posteriorly at the upper part of the cervix, and where the uterosacral attached to the cervix is called as the torus utrinus. This point is called torus utrinus. This is where the early endometriotic lesions are classically seen because of the fluid collection in the POD being the most dependent part of the pelvis, and your commonest site of lesion is here. You can see a lot of superficial small deposits on these uterosacrals even in this image. So normally, how does the uterosacral look? They are smooth, linear. I'm talking about not only the laparoscopic appearance, even the ultrasound appearance. They are smooth, linear, and hyperechoic lesions. This is a transvaginal ultrasound. This is a transrectal ultrasound. I've done both because this was an unmarried girl. So I've done a transrectal ultrasound for this patient. And in both these cases, you can see the uterosacral will classically stand out as an hyperechoic lesion. And towards the point where it's attached to the cervix, there will be tapering of the uterosacral ligaments. This is classical of a uterosacral ligament that you can always see. And when I do my transrectal ultrasound, after I see POD, immediately what I'll be seeing is the uterosacral ligament and it's attached to the cervix. So the orientation is reversed when you do a transrectal ultrasound. So normal cutoff for uterosacral ligament is 3 mm. And anything more than 3 mm, always suspect or deep endometriosis in the uterosacral. More so seen on the left side because of the peritoneal fluid dynamics. And whenever you see a uterosacral DE, always rule out a parametrial and ureteric involvement. Why? Because when there is going to be an uterosacral involvement lesion having more than 1.7 centimeters in size, more than 17 mm, there is a high chance that these patients can have associated ureteric or deep endometriosis. So always make it a point when you see uterosacrals, look for the parametrial and the ureteric involvement in these patients. So there are two types of uterosacral endometriotic presentations. They can either present as thick, stiff hyperechoic uterosacral lesions, or they can present as your hypoechoic deep endometriotic nodules. So what is the difference? These hyperechoic uterosacral ligaments are going to be very taut lesions. So they can either be because of your microscopic deposits onto the uterosacrals. Just as in this case, you can see on the routine 2D and the Doppler, see, look at the vascularity on that uterosacral ligaments. Hypervascular, these are the cases which will have increased vascularity because of the microscopic deposits, also causing a little fibrosis. These ligaments try to stand taut and they're not quite flexible as shown in the previous image. Okay, so these are going to be taut lesions. And when it comes to your thick hyperechoic uterosacral ligaments, these are generally less tender. They look very severe, but they're generally less tender and they're less often associated with other organ deep endometriosis, but quite difficult to pick on ultrasound because, see, this looks almost like a normal uterosacral ligament, but when I go further to that point of attachment, look at the irregularity on these uterosacral ligaments. All minor irregularities because of the fibrosis in these lesions. So these are the lesions that are very difficult to pick up, but they are quite classical of an uterosacral deep endometriosis. So they can either be a microscopic lesion or it can be a fibrotic lesion because of a chronic inflammation. When it comes to endometriotic nodules, these are going to be solid hypoechoic nodules. Okay, why are these solid hypoechoic nodules? Because they are going to have more of endometrial glands and stroma. And there is a little bit of fibrosis, but these are going to constitute a lot of glands and stroma, giving a hypoechoic appearance to these lesions. I'm sorry. And they're going to have a strong imaging histology concordance. What does that mean? When I'm going to image these lesions on ultrasound, when I'm going to do histology for these patients, they're going to be quite correlating when I'm going to do the final histopathology of these lesions. And they're quite less frequent compared to your those thick taut uterosacral ligaments. These are less frequent and very difficult to pick up. And these are going to be more tender. Whereas the thick uterosacral ligaments are quite less tender. So these are going to be more tender, but less frequently seen. And these deep endometriotic lesions can often coexist with your thick uterosacral ligaments. And they're going to need a complex surgery because they are going to have a deeper infiltration into your posterior parametrium also. And they're often associated with other organ D, whereas thick uterosacral is not necessarily associated with other organ D. Moving on to cervical endometriosis, I'm putting it in general because the endometriotic lesions, when it comes to superficial and deep, the appearances are same. So the cervical endometriotic lesions, if they're going to be superficial lesions, as you see here, you can have a superficial hyperechoic patch, serous irregularities, small patches here. And then you can have small hyperechoic spots and small hyperechoic nodules on the cervical lesion. When it comes to D of the cervical lesion, you can see this classical hyperechoic patch on the cervix in both these lesions. You can see the D from the ovary penetrating the cervical lesions and giving the classical appearance. And the vascularity is also going to be patchy in these cases. Moving on to vaginal endometriosis, they're often underdiagnosed on ultrasound, quite easy to pick up, but often underdiagnosed because they're not routinely seen for. So these, look at this case, you can see the small hyperechoic deposits on this tissue. I'm talking only about these and not these hyperechoic spots. These are air bubbles. Beware of all these hair pockets because these air pockets are often mistaken for endometriotic lesions. So These are the endometriotic lesions. You can even see a small adhesion band here between a small superficial endometriotic patch here on the cervix and on the vagina, and a small fibrotic strand there. And here you have small deposits on the vaginal wall here. Here you can see the thickened vaginal wall because of the fibrosis there. So it's often underdiagnosed, and it can often be seen as thickened vaginal wall in the posterior fornix, just as I've shown you. They will either present as dyspareunia and burning sensation in the vagina. Classical, all these patients where I've taken these images, these patients had one thing to say when the probe was put in for the TVS. They all said, I always have this burning sensation at the point where the fornix is, where the fourchette is there, or when I'm putting the probe at the posterior fornix, they say there is severe pain or burning sensation. So in all these cases, I can do something called gel sonovaginography. So what is this gel sonovaginography? I take 12 ml of ultrasound gel, sterile gel, and I take it without air. That is very, very important. It's quite difficult to take without air. I put the syringe into the gel, and I then take the gel into the, I put the syringe into the gel bottle, and then I withdraw the gel so that I don't have an air bubble. And then I insulate into the POD, and I do my imaging. Can you see? I can very easily see the superficial endometriotic lesions here. I am visualizing your posterior fornix. There is hardly any lesion here. This was actually an air bubble. Then I rotate my probe and see that was actually an air bubble, but there was nothing else seen here. So there was no lesion. So very easy to see gel sonovaginography in all your confusing patients or quite difficult to diagnose cases. You can use your gel sonovaginography. They'll be visualized, or even your small vaginal wall and posterior lip, cervical lip deposits can be seen. So I have only few more slides. So on moving on to D of the anterior compartment. When it comes to anterior compartment, your urinary bladder D is common. Next comes your utrovesical fold and your ureter, which is relatively less common. So when it comes to urinary bladder, I put a reverse orientation so that it will be useful for people who are doing a transvaginal ultrasound. You have your bladder neck. We'll talk about the basic anatomy first. So you have the bladder neck, and then you have the trigone of the bladder, and then the bladder base, and then the bladder dome, and then the extra-abdominal bladder. So the most common sites are your bladder base and your bladder dome. They are the commonest sites of bladder endometriosis. So here I have cases of bladder DE. You can see this is the muscularis of the bladder, and you can see the muscularis widened because of the DE lesion here. When you closely up here, you can even see the irregularities on the bladder wall here because of the fibrosis caused by the endometriotic lesion. This patient typically told me at this particular, she said, whenever I have my periods or when I'm close to periods, this particular point burns. So when I saw an ultrasound at that point that she was mentioning, I saw it was a bladder DE there. So here also you're able to see bladder DE in these patients. Often seen as hypolipoic lesions, better seen in the seen with the urine in the bladder, because you get a classical contrast. When the bladder is empty, the contrast is quite difficult and the lesions are quite difficult to see. So very easy to see when there is urine in the bladder. And when you see such lesions, always measure the distance from the urethra and the ureteral opening. So ureteral opening, how to see, I will be talking about it next. So here we'll be seeing about ureteral endometriosis. So first let me talk about the video here. You're able to see the ureteral opening here where you had the jet of urine, and from there I'm starting to trace, that was the ureteral opening, jet of urine again. I'm starting to trace the ureter, so you have to keep manipulating your probe to get the long course of the ureter. So here I'm able to get the long course of the ureter. When it comes to the angle, I've quite compressed in this patient. So I'm trying to relax the probe and get the ureter in track now. So in few seconds, you'll be getting the ureter in track. You're seeing another jet here, and you can see the beautiful ureter here, okay, which is going lateral to the ovaries. So classically seen, and I never encountered a case of ureteric endometriosis because majority of my imaging is to do with infertility. Maybe a routine imaging specialist will have more cases of ureteric endometriosis. So that's why I wanted to show you how to trace your ureter properly. And these are seen in 50% of in 50% of ureteric endometriosis. These patients are quite asymptomatic. They will necessarily not have any symptoms or present as an HUN or as dilated ureters, which is seen as incidental finding on ultrasound. Isolated ureteric endometriosis is very, very rare, which I've already told. They can be intrinsic or extrinsic lesions. Intrinsic lesions are developing from within because of the endometriotic deposit there. Extrinsic lesions are an adjacent endometriotic lesion being there, and because of the fibrosis, the ureter being pulled into the fibrosis is what is called the extrinsic fibrotic retraction. So always RSS ureters in all your deep endometriotic patients. Try to at least look for the ureters. Moving on to parametrial lesions, I want to talk about anatomy always. So parametric lesions, when it comes to the uterus, you can have an anterior parametrium or the lateral parametrium or the posterior parametrium, as we've seen in our anatomy textbooks. So all the three parametrium can be involved, or it can be sometimes when more than one or two parametrium, anterior and lateral and posterior can be involved together. So often indicates complex disease. It can be involving the ureters, uterine arteries, and the surrounding nerve fibers, and they're going to have present with severe pelvic pain, or they can even present as chronic nagging, chronic pelvic pain. These lesions present as irregular, ill-defined hypoechoic lesions, often with poor vascularity. And I also already said they're going to have severe symptoms needing multidisciplinary approach. And why I put this image here, because I just mentioned they're going to have poor vascularity. But look at this case. This case, the imaging is also different. It's not the classical hypoechoic, but an hyperechoic lesion. It is looking here. You have an ovary here, and you have the lateral pelvic wall here. So when you have an hyperechoic lesion, when you do the vascularity, you can even see the feeding vessel entering onto the lesion there. So why is this hypervascular? Is because of the omental patch being stuck at that point. So as I already said, whenever you're going to have omental patch, these patients are going to be hypervascular. So here you can see the corresponding laparoscopic image is going to look like this. You're going to have an ovary there, and you have an omental patch sitting on the lateral pelvic wall, giving a increased vascularity and making your appearance very different from the classical hypoechoic lesions. So I'm just going to be sticking on to only the imaging when it comes to anterior, lateral, and posterior. So this is a case of anterior image, parametrial endometriosis. Here you have the bladder, here you have the uterus. And as and when I move the probe, I was able to see an hypoechoic endometriotic lesion going on to the very close to the bladder serosa there. And when I get to try to get the vascularity of these lesions, they're going to have this patchy vascularity. And when it comes to the lateral lesions, again, you have the ovary here, you have the uterus there, and I see an hypoechoic lesion between the uterus and ovary in the lateral parametrium. And again, patchy vascularity. And look at this lesion. You can see a classic nodularity in the lateral parametrium, and look at the hyperechoic foci on the wall of this lesion. Very classical of an endometriotic lesion. I put the video for this lesion, for this patient. Can you see? This is the uterus, the lateral aspect of the uterus. I see something. I'm not seeing the clear serosal integrity there, so I have been moving my probe further, and then I see this endometriotic lesion here sitting in my anterior parametrium, okay, which is very beautiful to image on your ultrasound. So posterior parametrium, again, you can have posterior deep endometriotic lesions along with uterosacral lesions, as you see in this patient. And in this patient, it was coexisting with the lateral parametrial involvement. You can see there is a lateral parametrial patch here between the uterus and ovary. And because of the serosal irritation, you can see even the thickening of the ovarian serosa here. So which is classical of your parametrial posterior lesions, okay? Again, vascularity is going to have a patchy vascularity. Just a word about foam, because there's a lot of discussion about foam nowadays. So what is foam? It is the focal adenomyosis of the outer myometrium. So this is very different from your routine adenomyosis. So what is routine adenomyosis? Because of the endometrial glands infiltrating from the endometrium onto the myometrium, you're going to have endometriotic lesions in the uterus. But this is ulta. So how does this happen? Is because you have an D lesion in the pelvis, like on the ovary or on the bowel, as I've shown in the previous slides. This D lesion goes and sticks to the posterior surface of the uterus, causing the serosal integrity to be broken, and these lesions start infiltrating onto the uterus, giving a foam here, okay, which is the focal adenomyosis of the outer myometrium. You can see again a bowel lesion here. This I have done a 4D here, and you have a bowel lesion here causing a foam here, and here you have again a bowel lesion causing a loss of serosal integrity. Here you have the uterus, here you have the short axis of the bowel, and look at here alone the serosal integrity is lost, and here also the uterine serosal integrity is lost. And you can see the bowel endometriosis. I'm finishing in a minute, Mama. I can understand I took too much of time. So, and then these are quite seen even in your ACUM patients. You know, ACUM, accessory cavitated uterine malformation, can also come with posterior adenomyosis. So these posterior adenomyotic lesions can get, adenomyotic lesions can get adherent to an D lesion and also present. So to summarize, I'm just finishing. So your typical lesions, ovarian endometriomas, have a ground glass appearance with hyperechoic flex, and they can have the classical bird's nest appearance. Atypical lesions can have the varied appearance like a fluid level, and your hyperechoic lesions are solid looking. And your superficial endometriosis can present with an hyperechoic foci or as a peritoneal pocket, as hyperechoic spots. In all these cases, try to use your sonopodography to see your superficial lesions better. For your deep lesions, always measure in 3 orthogonal planes, be it any deep lesion. And for bowel, try to look for all the bowel signs, try to look for the sliding sign, the signet ring sign, mushroom sign, and all the signs. And for your uterosacral DE, always be cautious. Look at the uterosacrals whenever you have deep endometriosis in the pelvis, because they're the commonest site. Always remember that. And look for loss of serocell integrity for all your DE lesions, and try to pick up your foam cases. And for all your vaginal and posterior cervical lesions, you can do your gel sonovaginography. So to conclude, bowel endometriotic lesions and superluminal endometriotic lesions are very often reported as normal in ultrasound and MRI, because superficial endometriosis is quite difficult to pick, but actually when you have an eye for it, you can see it very easily. So that's why I say what the mind does not know, the eyes does not see. So better we start seeing these lesions, so that the eyes, once we start reading about these lesions, the eyes gets trained to see these lesions. Always beware of echogenic fluid in the POD. When you see an echogenic fluid, it's not always PID. Always think about endometriosis. Chronic pelvic pain, always think of endometriosis. And delay from the symptom onset to diagnosis by a laparoscopy can always be overcome by a patient ultrasound. Thank you so much for the patient listening. I know I've taken too much of time, and hope it was quite useful. Thank you so much.
Gaja?
Thank you, Rajalarasi. It was a very elaborative and excellent presentation with nice, beautiful ultrasound images. So yeah, I was you told about the sliding sign, comet sign, mushroom sign, and all red Indian head signs. So many signs of deep infiltrating endometriosis. Very nice presentation.
Thank you so much.
Yeah. Okay, Rajalu, I just have one question only. So when you ask the patient to do an MRI, when is the condition you tell the patient you really need an MRI to diagnose an endometriosis, or do you think that MRI is not at all required, and by a good ultrasonogram or a 3D or a 2D, we can just find out any kind of deep infiltrating endometriosis or superficial endometriosis or whatever may be?
So MRI, definitely when you're going to have complex endometriosis, because the ureteric involvement, not the entire course of ureter can always be traced on ultrasound. So you can't go up till the lateral pelvic wall. It's not always easy, because the anatomy is not smooth all the time, especially when you're endometriotic cases. So when you have complex pelvic lesions, when you're going to have ureteric involvement, when you're going to have associated hydronephrosis, always your MRI mapping is important along with your ultrasound imaging. Ultrasound imaging can guide you for going towards MRI, but ultrasound cannot be solely the imaging modality for all your complex lesions. So that is when you have to do. And anyone, see, all these lesions requires a lot of time, lot of patience, lots of expertise. Not everyone will be able to do all these images. So anyone who is less expertise, they can very well go ahead with an MRI, because this is quite time consuming. You need to put a lot of time and effort and a lot of learning curve too. So definitely MRI, I would say MRI for all the beginners who are not very well trained, and also in all your complex lesions. Definitely MRI will be helpful.
Yeah, correct, exactly. Thank you.
Soumya?
Yes, ma'am. So thank you so much, Dr. Ilavarasi, ma'am, for excellent and highly practical presentation. I do have one question, ma'am. So from perspective of IVF specialist, so is there any particular ultrasound sign which can probably add a valuable insight in cases of a difficult oocyte aspiration? Like which ultrasound markers will help us in guiding that the technical process of oocyte aspiration might be difficult, like from the signs that you presented?
Yeah, definitely sliding sign, ma'am. So if an ovary which is not fixed, which is not adherent, has to slide freely from the uterus or from the surrounding adnexal structures. So first thing that we have to look for is always the basics. So first the sliding sign. If the ovary is freely moving, then you're very sure that the ovary is not adherent, then your pickup is going to be quite easy. So only then you if you're going to be talking about endometriosis of these cases, then definitely you have to look for the DE lesions, the hypoechoic patches and all that, because if you're going to have an endometriotic lesion, which is going to be a DE lying in your track of pickup needle, then you're going to be piercing through the DE lesion, and you're going to give a little bit of post-procedure infection risk. Everything is going to go high. So DE, if you're going to have DE or an very complex endometriotic patients, always get your MRI and ultrasound. Yes, if you are very special, expertised in all these imaging, then you can do. Otherwise, get an MRI, be clear about your planes, and then map the cases, and then go ahead with your OCR.
Okay, thank you.
Ramani ma'am, your expert inputs, ma'am.
excellent presentation comparing the
Ma'am,
ultrasound with the
one.
laparoscopy. As you said, it needs lot of training and meticulous work. That's
Imaging.
no doubt.
Yes, ma'am.
And Soumya's question regarding oocyte pickup. I feel oocyte pickup in endometriosis is very tricky. Like a simple case where it is fixed, it will not have any problem. But invariably, the endo patients will have associated adenomyosis and the ovary will be behind. So the thing is, we need to go through the uterus most of the times, but we need to be very careful not disturbing the endometrioma. So it will be difficult only. So in some in some cases, I feel pre-pickup laparoscopy will definitely help, because that you can remove all the endocyst and you can make the ovary mobile, and then it will be easy. We can make it away from the uterus. Gajadeepan, what is your take-home message? What do you feel in oocyte pickup in endo patients?
Ma'am, as you said, ma'am, it is very tricky and we should be very careful in dealing
Yes.
endometriosis during a ovum pickup. So it's very tricky, as you said, ma'am. So if
Most often we
after,
find it difficult.
it
Ma'am,
can be,
if
it is
you do
always better to avoid pricking,
Considering
and
that,
we should be cautious in doing ovum pickup in patients with endometriosis.
Yes.
yeah. I'll just share the thing.
Yes,
Ramani
Shalini.
ma'am, so many times it's always a debatable question whether to do the egg retrieval first and then remove the endometriosis. So many patients are being sent, but when we do the ultrasound, we find it is so difficult. All the follicles probably they are sitting above the endometrioma where you can't even reach them. So I think that careful evaluation is very, very important, where only in selected cases we can do the egg retrieval and not in all, if such a big endometrioma is there.
So
Ma'am,
probably such cases where
Yeah.
you have a large endometrioma or when access to pickup is very difficult,
Very
then
difficult.
probably
Yes.
we need to go for surgery
Surgery first.
because
Yeah.
by doing a surgical laparoscopy in infertile endometriotic patients, there is always the EFI score that will help us to guide both
Yeah.
the surgeons, as both the consultants as well as the patient, whether we
Yeah.
need to go straight away for ART or whether we can expect spontaneous conception, all those things. Proper surgical correction, definitely it will improve the outcome, either spontaneous or following that ART.
And definitely the
Ma'am,
results are excellent once a good surgery is done.
Yes,
I mean,
yes.
many
And the
patients, they
quality
do
of the
continue.
embryos, quality
Yeah.
of the oocytes are definitely much better,
Yeah.
even though you get lesser amount of follicle, lesser amount of
Yeah.
oocytes and less follicle stimulated, the quality is definitely better and you get good embryos also.
Yeah.
Ma'am,
Just one
I have
question
a
to you,
slight.
Ramani ma'am. Sorry,
Yes,
I'm
ma'am.
interrupting.
Yeah.
Okay.
What's your experience, ma'am? Like, suppose you have left the endometrioma and you have done the IVF. Maybe it wasn't that bad, or there was one-sided
Yeah,
endometrioma.
sometimes we do
So,
that.
yeah.
Single
So,
endometrioma, we leave it, we ask them to go for
yeah.
a straight
So, do
away
you
ART.
find your results? I mean, if you're going in for the frozen transfer, maybe we down regulate. But even
Yes.
after the down regulating, you feel the results are less with the endometriomas, or are the same? Or what is your experience, ma'am?
I think with down regulation, our results should be at par with male or tubal for factor. But I find earlier in a mild and minimal mild endometriosis, they have a better outcome than the moderate and the severe disease. Severe lesions, even though we do an ART, the results are definitely much lower. So probably put to me, I will take into consideration the size of the endometrioma, the symptoms of the patient are very much important. Then again, sometimes what we do is we know the complications of the patient conceiving with an endometrioma. Raja Ilarasi has beautifully pointed about the decidual changes in the ultrasonogram. These decidual changes not only causes the endometrioma to grow up, it looks like malignancy as you said, but sometimes there will be stretching of the tissues because of deserialization, fibrous tissue. It can lead to bowel perforation. And it can lead to spontaneous intraperitoneal hemorrhage and rupture of endometrioma. All those things are very, and sometimes you do get abscess formation. following ovarian, oocyte pickup. We have come across many of the patients referred from outside with the ovarian abscess. And even if it is not a pickup, sometimes spontaneous ovarian abscess also. Of late, last 2 months, I have operated 3 or 4 cases of ovarian abscess in endometrium. I don't know how it happens, but still we do come across. So I think even if you do embryo freezing, maybe to reduce the adverse effects of pregnancy outcome, we can go in for surgery, then do the embryo transfer. That will reduce the ROS levels also. Implantation will be.
Yeah, that's correct.
After surgery, you do give the patient down regulation for 3 or 4 cycles, then go for transfer.
Yeah,
because most of the patients, they do have associated adenomyosis also. That is going to reduce the results very badly. So in such cases, long down regulation before ET will be helpful.
Ma'am, I have one different concept here, because when we do surgery before a pickup, many times the ovarian reserve can go down in these patients. So there's another concept where when the ovaries are even adherent, even if it is going to be adherent to the anterior wall, you can go for an abdominal pickup in these patients.
I have done
Get
that
the
also,
oocytes first.
abdominal pickup also I have done. But I agree with Shalini. I think I am a strong proponent of surgery before.
Even I am.
Yes, ma'am. I'm also the same,
Yeah.
ma'am. Actually, surgery helps you if you have done by good laparoscopic surgeon without affecting the quality or the compromising on the oocyte thing. The results will be much better after doing a surgery and doing a pickup afterwards.
Yeah.
And as madam said, once you down regulate for 2-3 cycles and do an embryo transfer, the implantation rate is also much higher with these patients.
See, then I will tell you share one small case. Patient is a known case of endometriosis, and she is also a known case of congenital adrenal hyperplasia, diagnosed much earlier, and she was on steroids. Okay, 2 cycles of one surgery she has had outside, followed by 2 ART, like 1 pickup and 2 transfers, failed. So then she came to me. Then again, I started her on, 1 cycle, I did a oocyte pickup, I froze the embryos, down regulated, and then no conception that time also. So the patient was very much depressed because they had 3 FETs and failed. So then I thought, why? Because there are now literature evidence to show that redo surgeries can definitely reduce because I had an extra spare embryos, and there was suggestion of mild hydrosalpinx as per the previous ultrasound. So I thought, why can't I knock off that hydrosalpinx also? So I did addisolysis, clipped the hydrosalpinx, and put her on down regulation. Okay, then after down regulation, like this patient did not want to have a FET cycle immediately, and she was mentally upset. So once when she regained after down regulation, I thought I will give her dydrogesterone from day 5 to day 25, which is a retroprogesterone, does not inhibit ovulation, and it is a good immunomodulator. The patient conceived spontaneously on the 3rd cycle, and recently I delivered. She did not have any complication except that as she was on steroids, she developed GDM. That's all. Otherwise, there was no evidence of placenta previa because we expect low-lying placenta accreta syndrome, preterm labor, and hypertensive disorders. All those things are common, and increased incidence of miscarriage, ectopic. So she escaped all those things, and she had a healthy baby delivered by section because it was a breech presentation.
Wonderful.
So
that
means spontaneous conception is still feasible after failed ERT because there are a lot of references had been given for this. There are now a lot of studies, many case reports, and as well as case series are published. Like
very good. Yeah. Raji, I think I have to thank you a lot. I think one slide you put, what the mind doesn't know, the eye cannot see. Just before you put that slide, I was really mesmerized by all your images, video. I was saying, I'm doing a lot of endometrial scan. How come I missed all those things? That's correct. Then I thought, okay, I don't know what my mind doesn't know, I cannot pick up. So correctly, you put that statement immediately. I never thought like perio endometriosis, you can make out even the bowel, you can make out, but bladder, ureter, and the minute things what you have put, even that cervical, vaginal. I'm really very, I think you really did a great justice
Great
to your
job, yeah.
topic.
Thank you so much.
And seriously, and it was a, ma'am, I think she was the last person for me to ask. She never told no. She told, okay, ma'am, for you, I'll do it, no problem. So thank you so much, Raji. It was a wonderful, wonderful presentation. Thanks.
Yeah,
Thank you
one
so
more
much.
thing,
Because
Dr.
both the
Chitra,
young
I'm
speakers, they
interrupting.
did very well.
Yeah,
Yeah,
ma'am.
Both young
Yeah, that's
speakers,
true.
they did very well.
yeah.
Yeah,
Dr.
both.
Chitra,
And both. Yeah, Shalini.
yeah, one more thing. Actually, all these webinars, we are putting the recordings on the YouTube. So I hope both the speakers don't have any objection if we put your this recorded lecture on the YouTube at the
They'll
IFS
be
site.
very happy. They'll be very
No
happy.
problem. No
Yeah,
problem.
That's
okay.
okay. Yeah.
Yeah.
No, it will be benefit others. Okay, many people wouldn't have
Yeah,
joined, but it will be benefit others. Always available in IFS SIG.
yeah.
So thank you once again. I now
Uh,
request our chapter secretary of South Tamil Nadu, Dr. Gajadipan, to please deliver the vote of thanks.
Yes, ma'am. Thank you, ma'am. As we bring this session close, I thank everyone who has made this webinar a fantastic webinar. I like to thank our president, Dr. Neena Malhotra, ma'am, who's a mentor and a guru of me, and the guest of honor, Dr. Kuldeep Jain sir, Dr. Roya, madam. And I would special thanks to Dr. Ramani Devi, madam, who gave her insights about endometriosis. She's a pioneer of endometriosis, and I'm very excited to see her 1,000 patients come and publish her results on the microRNA. And I would also like to thank our great two speakers, Dr. Surya, who has talked about the biomarkers. Even though we know about endometriosis, the gold standard is laparoscopy. The biomarkers reduces the diagnostic delay. She was talking very well about all the markers, the microRNA, and all the blood and the urinary markers. I think we have to wait till the panel comes, and once we validate and we can take this into practice and diagnose endometriosis early, which will be very useful for the adolescent endometriosis patient. And the second speaker, Dr. Raja Leversi, who spoke very well, excellent on the imaging modalities and the imaging ultrasound in endometriosis and all our signs and the imaging which with the beautiful images and slides. Last but not the least, I cannot leave without thanking Dr. Chitra madam, who has coordinated this webinar very wonderfully and coordinating all the very good speakers and with all the guest speakers, everybody. Thank you, ma'am. With a short interval, you made this webinar a fantastic and excellent, which was, I learned many things from this seminar.
I too
Very
learned a
excellent.
lot. I mean, seriously, biomarkers
Yes, ma'am.
anyway, I was telling her because I gave it, but ultrasound, I'm really mesmerized. Thanks,
Yes,
Ajit.
ma'am. All the chairpersons also. Very well,
Yeah, good
fantastic,
enough.
very fantastic. And with a short interval of time, both the speakers said yes, and they did a very fantastic job. So I
And
thanks.
I'm so happy that is the youngsters which has to come up. They're like they have to do that. That's the one thing which I really loved it. So when given chance, no, they are going to do the best. So
Yeah.
I really
Thank you
sincere
for your
thanks to
wishes.
Surya also from my side, from my SIG group, and Rajali and the chairpersons. We have Soundarya, Deepa, all from our committee. Thank you so much for sparing that time. Okay, and let us have more collaboration future, Gajadipan. So let us do more on endometriosis.
Yes,
We
ma'am.
already planned with our committee. Like we're going to have a lot of talks in the colleges, schools, make them more awareness so that they have an early diagnosis, so they don't have to go to the severity and where treatment becomes very dilemmatic.
True.
Okay, thank you once again to everyone. So let us meet again.
Chitra, we
Thank you all. We'll meet in the
started
next
the Endo
webinar.
Society of Tiruchi chapter. Tiruchi
Yeah,
chapter
madam.
Endo
Surely,
Society.
madam. Pakka. I'm always, you're my guru, my role model. Whatever you send, it's done. That's the only thing. Thank you so
Yeah,
much,
ma'am.
ma'am.
Thank you.
Thank you.
And
Thank
thank
you.
Thank you.
Ma'am, you need to be present for all endometriosis webinars. So we need to have inputs from you for everything. I'll be informing
Definitely,
you.
I'll be there.
Okay, ma'am.
Yeah,
Thank you,
ma'am.
ma'am.
It will be a
Thank you.
pleasure.
Thank you, Chitra ma'am. Thank you,
Bye,
Ramdev
bye.
ma'am.
Bye,
And all
Shalini.
speakers.
Bye,
you.
Gajadipan.
Thank you.
Bye,
Bye-bye.
Soumya. Bye, bye, bye.